Good afternoon, Dr. Scott. I'm Caitlin. I'm the physical therapist from Fleming Therapy Services here in Glen Allen. Go ahead and introduce yourself.
I'm Scott Evashena, pediatrician at Acorn Pediatrics at the corner of Three Chop and Gaskins.
Excellent. So we're here today to just kind of have a conversation and answer some of your questions about torticollis. Kind of have a nice little conversation about what that is and how we can help our families and potentially new referrals when they come into either one of our offices on what they need. So I thought we'd start with like, what is torticollis? What is that? How do we treat it? How does the doctor see it? How does the physical therapist see it? So I can
Oh,
answer that question, or if you want to start, you're usually the first one because you're seeing it in the office first.
yeah. So usually it presents, I guess, in one of a few ways. The first one is sometimes we'll have kids who have a head tilt, and the parents will be like, now that we hold our head upright, and so it's usually sometime between like 2 and 6 months where we've got some head control, and the parents will notice that there's like a tilt.
Yep.
And every time they hold the baby up, the baby goes, Doot, and they're like, oh,
Yep.
and it's just more comfortable for the kid. And then earlier, we usually see it where the parents will just tell us that they've noticed that the kid doesn't move all the way head over the shoulder, and always looks to one side. And some of that, is normal in the beginning because you have your like fencer reflex where with the arms extended, the head will turn that way. But again, that should fade by around 1 to 2 months. And when it's not fading is sometimes when the parents notice it. So that's my boring answer.
That's similar to what we're looking at too. Usually it's 1 to 2 months if they're not turning their head, or if a parent is constantly seeing a head tilt. Sometimes they'll see that head tilt, maybe not necessarily when they're laying on their back, but when they try to sit up and do some head control, like you said. Usually those are the two big red flags. Sometimes you might see a little bit of both, where they're just tilted when they're laying down and they're way up in the sky looking up somewhere, and they're not able to do that on the other side. So we frequently see that.
Earlier on, sometimes like post birth, if it was like long
Yep,
birth,
long labor.
right, long labor, we'll see the tightness already with a
Yes.
lump along
Yep.
the muscle. But that is relatively rare.
Dr. Scott, what do you usually recommend for parents when they come into your office? Like, what do you say constitutes a referral for torticollis for PT? Or what do you give them when you are seeing that child for that?
For me, I do my own range of motion stuff. And, for me, my goal is chin to shoulder on
Got
both sides, and then ear to shoulder nearly on both sides. And I check for symmetry and make sure they can do it equally on both sides. If they cannot, then I demonstrate or give them the handout from like the AAP on Torticollis, which has some of the basic exercises. And then I gauge whether or not the parent is actually ever going to be able to do that to their baby
Yes.
based on their response to me doing it to their baby.
Yes.
Because it can look kind of crazy.
Yep, for sure. It's a little uncomfortable for some parents and some babies.
Yeah, and so, depending on the infant's personality and whether they're tolerate it well or
Yes.
whether the parents can tolerate it, I let them try on their own if I think they have the ability. If not, I refer.
Okay.
Or if it's like really significant and I want to make sure I'm not missing something different, I like then to get like the PT's
Mhm.
experience with it.
Yes, of course. Do you usually refer like after 2 months, before 2 months? When do you normally do that? Two
I
months
mean,
before?
so I do it the second I find it, right? Because like the tightness is only going to get tighter
Right.
if they're not doing anything. And so for anybody who doesn't know what torticollis is, I guess we sort of explained it, but we didn't
Yep.
explain the underlying mechanism.
Underlying cause. Yep.
Is often the sternocleidomastoid muscle
Right.
being tight. Um, and again, just like any of us old people with like tight hamstrings, etc., it doesn't get better just magically on its own. Usually, you have to do something in order to get a uh, looser muscle or
Right.
more stretch.
And as PTs, we appreciate an early referral because we can get into that and get it started before these babies have all these asymmetries that we could have corrected very early. And they're starting to acquire all these beautiful skills. And then we've got to say, oh, well, wait, we have the skill, but we only have it on one side, or we only have one arm that's working. And we can really get in early and address that tightness and help them get symmetry, like you said, so that when they're acquiring these developmental skills, then we're not having that asymmetrical motion.
Yeah, and I mean, I had a kid last year actually, or the year before, who actually had some facial asymmetry.
Yeah.
That I guess there's like some data showing decreased growth of even just like the bones of the face,
Right.
secondary to torticollis, which was crazy to me because I was like, I could totally see you getting a weird head shape and like a flat trapezoid head
Right.
from that, but I didn't realize that we could also have
So much asymmetry. Yeah, I frequently see a lot of times when we have just some flatness, that point of least resistance, that parallelogram head, can create that strong ear shift, which then creates that asymmetry. Like you said, I've had kids with eyebrows that sort of look a little higher than the other eyebrow, or an eyelid that kind of droops like over top of that eye because, they just don't have that symmetry on that side. So I completely agree with you. I think that you're seeing a lot more of that now with some of the torticollis because plagiocephaly is so common with it. We're kind of treating it all. So we've got to look at it. That's why early referral is so great, because you can treat that at 2 or 3 months and hopefully get that symmetry much, much better.
Yes.
Standpoint.
What are the exercises you guys do different than the ones that are just in the handout?
So that's a great question. I do some that are different. So those are the basic ones I usually start with. And I try to tell parents all stretching should be comfortable and in a tolerable position for that baby. So oftentimes when they're screaming bloody murder at mom, we're not getting a good stretch. We're not able to actually activate those muscles the way we want to do them. So what I do when I'm treating a patient, I look at response like yourself and say, how does the baby tolerate it? How does mom tolerate it when baby's not so sure? And we modify positions. So I will teach things in handling of a baby. So maybe we're not doing stretches just on the changing pad where we're doing some rotation and some side bend. We'll do it in some handling positions, some carrying positions. We'll do some more active motions with the baby. So once we've got some head control, can we do, some more of that activation of those muscles? Can we get them to look over and track and do those things that are a little bit more tolerable to them than us just kind of trying to passively move that head? Exactly. And a lot of times too, with torticollis from a PT standpoint, I'm looking not just at head, I'm looking at full body motions. I'm looking at the trunk of that baby, the lower pelvis of that baby. All of those things kind of have to rotate and move with us to acquire new skills. And if we can't get our head over, we're probably not getting arms over, probably not getting trunk over. And 90% of my children that I see have some type of kind of trunk restriction. They're stuck because we're kind of just tilted. So everything in our body makes us kind of tilt to one way or rotate to one way. And we have to sort of look at correcting those in a tolerable range of motion as well. So, sometimes I don't start at the head. I might start at the trunk and get them to activate that rotation more and then add in more of those traditional type of stretches that you maybe have provided to the family. And then as the baby gets older, I've noticed too that they're not tolerating those stretches as well as maybe they did when they're 2 and 3 months old. So we have to look at how do we change those positions? How do we fix that so that the baby's more actively involved in the stretching and mom can feel confident that she's doing them without potentially hurting her child and or not having tolerance to that position for sure. Is that something that you see frequently with your parents, that they just are afraid that they're going to hurt them?
Oh, yeah, terrified. Because it looks awful.
It
does. Finding that sweet spot in an infant between oh, that's a good stretch, and screaming is like a centimeter or less, and it can be really hard. And then even the carry ones where you're having them lay sideways, so that you can cause a little rotation on the head just passively. Some kids just hate it with a deep, dark passion.
They do.
And then the parents are, especially like if you're a parent of a 1 month to like 3 month old, right? Like you feel 100% confident that like your whole job is to keep your kid from crying.
Right.
Like you
And
don't,
hold their head.
right, you don't get broken of that until like your third kid, or at least like a 3-year-old, where you're like, wait, kids cry and it's
Right.
not my job to fix it. Crud.
Right.
And so again, doing something that your kid doesn't enjoy is very difficult for a first time parent
Yes, for sure.
with a new baby.
And I think that's where, when I look at my job, I try to find those positions that are the sweet spot. Like you said, what does this baby tolerate so well? How do we make this more fun, more motivating for that child? And sometimes early on, it's just the parent's face. How do I use their face to help the stretch? Can I get mom to lean over, dad to do the carrying stretch because dad's maybe a little bit longer arm, more comfortable than mom is. Mom's face can be that movable rotational component. So finding those sweet spots and things that work other than just kind of doing straight stretching is something that's so important for me to kind of teach to them, because they're getting the beginnings of it, but how do we progress it, right? Once they start tolerating it, how do we make that progress? Because passive range of motion only goes so far. We've got to get strength, and we've got to get some active range of motion there for that child too. So I definitely see that happening too. What tips do you give to parents about like just developmental skills when it relates to torticollis?
So this is probably anti-PT thinking, but like, so I'm very much about like family function. And so I don't give a lot of very specific, there's people who be like, you must do 30 minutes of tummy time per day, or else your baby's going to be deformed. And I am much more of like, hey, your kid laying on your chest while you lay in a chair is tummy time. Your kid, up on your shoulder, resting up here with their head not supported is tummy time.
Right.
And that you don't necessarily need specific instructions or a specific amount of time.
Right.
And then in general, the amount of time you do doesn't impact where your kid ends up at the end of 2 years, right? So it's not like we did more tummy time, so he's totally going to make the NFL.
Right.
We did more tummy time, and so he is better at getting up on all fours,
Right.
7 months old, than he was if we just carried him around the whole time.
Right.
So what is your take?
That's a great question. So oftentimes, torticollis babies, they struggle with tummy time. They don't like it. It's hard. There's a correlation with acid reflux with them. So, that's even more uncomfortable. But like you said, I don't really give them specific times. I give them specific strategies to do this. So I try to tell them, how can we make this easier? So we start with chest from day one. We're working chest. And then I give mom and dad strategies of how that becomes harder by you leaning back in the chair instead of being upright in the chair. We talk about doing it on the floor, so you're flat and the baby is more flat, to work on that. Same thing with, like you said, over the shoulder. I do also try to get them to do some floor time, but we modify it with towels and boppy pillows and things that the baby will tolerate or get motivated by, so that it's easier. I've done it over the legs, just kind of have mom lay down, do a little bit of incline over the legs. Everybody recommends that at least 1 hour of tummy time a day. I think you set that goal, but you need to have realistic goals that the parent's not going to sit there for an hour to do tummy time. Right. I have expectations, right, especially on the third child. Right. So I usually recommend that, they try to set a timer for their baby. Once the baby's tried to do some tummy time on a boppy pillow on the floor or on your chest, set a timer, see how much they can actually do. And then you're getting some, but you're not overly stressed about the time component. Because like you said, it's important, but statistically, what is that going to do besides help them acquire the skill, which I think is 100% important. Don't get me wrong, as a PT, we need the skills, but we stress our parents out with too much of that time component that I think it becomes unrealistic for them to meet those goals early on. So my goal is to modify positions for tolerance, progress them so that we can get them to tolerate more just regular prone tummy time, and then we build time from there. And ultimately, we're trying to do that hour, but it's 5-10 minutes a day here, 5-6 minutes there throughout the day.
I also feel like kids do a lot better if they are at head level. So doing
Yes.
it up on a couch or up on a
Yes.
table,
Yep.
so that you can put your face where their face is. They
Mhm.
tolerate it a lot
A
longer.
lot longer. I usually have my parents when we're here. Some of them are really just not tolerant. Try to get on the floor, lay
Right.
down in front of them, talk to them, engage with them, because that's what they can see is you and they know you. And I think in this COVID world, it's been more challenging for me because they don't know the mom with the mask on.
Right.
So they're stressed out more because they can't see our facial expressions
Right.
and they can't see what we're actually engaged with them. So I've had to do a lot more parent education than I've ever had in a clinic because
That makes
they
sense.
only know mom's face. They can't see me. So
Right.
just kind of tolerating it and progressing there. I totally agree with you. I think it's important and I push for it, but we can't stress ourselves and stress our parents on the time component of it. That's just too much, especially sometimes for a first time mom too. I think it gets too overwhelming with all the things that you're expecting your baby to do.
And I guess there's all like the passive stuff too, where it's like, laying, if your baby has a left turn but is always sleeping in
Right.
the
You got it.
here, right? You flip them the other way. So
Them.
they have to turn to look at you.
Yes.
Same thing, like if they're getting stuck in a bouncy chair, and you're in the kitchen, like rotate the bouncy chair so that they have to work a little bit to look for you cooking in the kitchen.
Right. And I do that a lot of times, even just with tummy time. Like if you can't be on the floor with them and they're going to play on their tummy for a few minutes, you have an older child you're attending to, put them so they can see you. They can find you in the room, look for you. I do that the same thing with just positional play anyway for torticollis. It's so important that you find purposeful and positional play. And I think that's more important than specifically putting time to stretches or time to tummy time. I would rather the parent find that purposeful time of their day where they're getting the most benefit out of what we're trying to get for treatment. And then you're positionally playing
Right.
and making that purposeful. So like you said, you're getting that passive stretch or that active range of motion of the head, even side lying. We do tons of side lying with babies, tons and tons of side lying. It's good for that plagiocephaly, get that pressure off that head. It gives them some chance to bring hands to midline, see some visual tracking there. That's just that alone is going to be some help to help that rotation and that component for sure.
Makes sense.
What do you tell parents about? You mentioned like bouncer chairs and things like that. What do you recommend for parents? It's okay if you don't give the PT answer.
Yeah, so I mean, I hold the line on no walkers from the AAP.
Yep.
Walkers are bad. No one has ever learned to walk in the position that your butt is in a walker, and it doesn't actually help. And in theory, they are dangerous.
Correct.
But other than that, I love pretty much everything. I mean, it is a rare kid who I think is going to get hip dysplasia from a Johnny jumper, or if they do, there's something else going on, right? Because most kids don't tolerate extended periods of time, even if it's the best jumper on the planet or the best little exosaucer on the planet. I don't love the Bumbo chair because it's creepy. Um, but not necessarily because I think it's going to hurt your kid. And I think the Bumbo chair has a false sense of stability
Yes.
because it's the single most thing I have had fall off a kitchen counter with their kid,
Right.
of anything we've ever had.
Right.
So again, creepy. Kid looks weird in them, but they are functional as long as you don't put them on the counter and take anything more than a step away.
Right.
But again, like I have tons of families that worry about causing backbone issues, future scoliosis issues by being in any of these things. And the reality is like bodies aren't made like that. They
Right.
just don't break that easily. For kids with a lot of positional plagiocephaly, so like the flattening of the back of the head, I encourage the parents early on to put them in a jumper, even if the kid is like this in the jumper or in the exosaucer, because it's keeping that pressure off the back of the head.
Mhm.
And they get more core tone by flinging themselves forward to
Right.
get the toy that they want to get to. So again, that might not be a PT approved
No,
answer.
that's okay. I
But,
think it's okay. I think part of that is correct. Like that, to me, those items for a typical developing child probably aren't going to cause issues for a child. They're not going to be a problem for typically developing children. I think what happens with children with lower muscle tone, higher muscle tone, even torticollis, is that we have to build these skills so that they can build strength. And you can put them in a Johnny jumper and have them be upright. Of course, you want their head to be upright, but I also want them to build core strength. So how else what is a better position I could put them in that would build this, that's more functional? And I guess my problem with like Johnny jumpers and exercisers is our little hips are not made to jump until we're 2. Like that's what we're supposed to do. And we're atypical. Like we shouldn't be putting all this support around our chests and all of this support around us to kind of learn a skill. They're already struggling, they're already delayed. So I want to give them a chance to kind of build strength in typical range of motion, typical exercises. And I don't say that mom can't put her child in them, but I just recommend that the time be a lot less than sometimes what parents want to do, because the child may love it. So that's great, but can we love it for 10 minutes instead of 30 or 40 minutes for them? And I'd rather them play on the floor.
Exactly. But like, that's the hard part is like, what is your trade-off, right? And being aware of that within the family. Because like, if the choice is Johnny jumper, or we're still going to be in the car seat.
Correct. I would choose
probably pick Johnny jumper over the car seat. But if the choice is like free play on the floor, yeah, totally. And in general, same rule for pretty much everything. Like I was talking with the family this morning, where kids do more when you're doing more with them.
Right.
So like, family was talking about how their kids stopped talking when they started watching cartoons. And the problem is the cartoons, because when they're watching cartoons, you're not talking with them. And our brains are oddly social, especially when they're developing. And I still think it's amazing that it's hard for infants to learn a language by listening to it versus talking with someone.
Right.
Why is that different? Why is it if I play it on a tape, they won't learn it, but if someone is talking around them, they will learn it? But it does show us like sort of what helps kids. Like it's not your baby Einstein. It's not, it's nothing special. There's no product. It's you.
Right. It's engagement.
You interacting with your kid.
Right. You can have no toys on the floor and still get them to roll, still get them to crawl.
And that sucks, right? Because like it would be awesome if we could just buy something that did that.
Yep.
Because like I'm tired.
Right. Of course.
Everyone is tired when they get home. But it's what works.
Right. And I think that's why you have to be realistic about your parents' goals. Like, if you need a 15-minute shower, you put them where you got to put them. I'm not going to tell you not to put them in the bouncy chair. You just need to have them, like you said, in a safe space where that's allowing that child, safety while you can do what you need to do. I just recommend that we decrease our time in those things so that we can skill acquire and have that interaction.
It doesn't replace you.
Right. It doesn't replace you in any way, shape, or form.
Supplements you.
And
cooked dinner.
Exactly.
Other kids' homework done, and etc.
Exactly. And I agree. It has to be in a functional way for that family for sure. It's just too hard to not do that. I think that's great though, that your recommendation is functional and not just not doing it. Walkers, I agree with you though. I never recommend a walker to anyone. You can't walk with your hips that's supported and your trunk that's supported, and you just be a little
walk around like that for them and ask them, dude, walking like that, and so that helps.
Right. And safety too. Those are extremely dangerous. You're gonna probably be painting some walls.
I'm fully willing to admit they're cute as all get out when the kids go hauling down the road with them, but still.
Yeah, but you're painting your house and you're also checking to make sure that your child's closed the gate at the top of the steps, and there's a lot of safety concerns with this. I totally agree. What would you say your families come in when you refer for PT? What are their concerns going to PT for their child or their newborn with torticollis?
Right now, COVID,
Yep.
and not wanting to go to any place that's medical.
Yeah.
I mean, again, it's just a matter of not having a relationship yet with
Right.
the people, is usually the biggest hindrance. And then worrying that there's something more going on
Yes.
and the inherent avoidance that comes with that as a response.
Right. Yeah. And I think that that is tough now. I think with the medical, like you said, like just kind of feeling out families with COVID. I would say from a Fleming standpoint, I feel very, very safe working here and what we have protocol wise and how much I have to do between, in between patients and seeing patients myself and how we're, handling patients than themselves. So that kind of helps that security. But we also have telehealth options too, which I think it's a great option for a family that, has a newborn and maybe a couple other kids at home that they don't feel confident that they could get to a therapy center right now. That's a really great option that most insurances are covering. So we can do, a lot of parent education. We can do a lot of things over that telehealth model and a lot of demonstration. I think all of our therapists have become way more comfortable with that model since we don't have much of a choice not to, similar to yourself. So I think those are always great options. I think the other thing, like you said, that differential part of it, that's the benefit of a PT evaluation too. It's getting a second set of eyes on your child along with your pediatrician and kind of collaborating with your pediatrician if there is something going on. I'm going to do a standard torticollis, review with the parent, but I'm also looking at differential diagnosis. Is there something ocular going on or vision wise? Is there a mass there that we need to look at? Is there something neurologically going on that appears like it could be torticollis, but I really don't have use of that arm and I don't have feeling of that arm? Or oftentimes I see sometimes early on in my career, I get a lot of brachial plexus injuries with torticollis because of a trauma at birth. So we'd have something secondary going on. So I think with families at ease, like that relationship starts with that eval, right? We have to kind of look at all the differential things and say, how do we do that? And for me, if I'm seeing those red flags and I'm referring back to that pediatrician, I'm getting you the help that you need, maybe somewhere else, so that we are making sure that that child is getting treated properly for whatever underlying things might be going on other than torticollis.
Just want to bump in here really quick with a question we got from someone watching at home. What about baby wearing in an ergonomically correct carrier?
It's a great question.
Again, I have low concern for hip dysplasia in a neurotypical kid in any of the many assorted ways you can carry your kid. I don't care whether it's a Moby wrap and you have some sort of Cirque du Soleil training or whether it is the baby Bjorn, etc. And I think, again, skin to skin time is great. I think it lets you get a lot of stuff done. I think you can have them outward facing when it's appropriate and be talking to them while you cruise around the world and clean your house and do life. And again, I think it is unlikely to lead to any issues in a neurotypical kid.
Yeah, I agree. I think wearing's perfect. It's also great for those plagiocephaly babies. We're getting pressure off of that head. We're getting, visual stimulation. We can look up at mom, see mom. And like you said, once they're able to be forward facing, then you've got a whole new world out there. There's bigger head control. We can start a little bit more trunk and hands can start playing. I 100%, I think it's a great way to be able to do functional things without having them, I prefer that over anything else really container wise. I think that's a great, I take that over the car seat any day.
Totally, because you interact with them more when they're on you.
Yeah, sure.
Well, we are right about at the half-hour mark. We had a great audience the whole time. If there aren't any other questions in the audience, I'll open it up for just a second here while we close up, if anybody has any final questions. But both of you, thank you so much. This was a really wonderful, informative conversation. I was really enjoying it, and I'm sure our audience was as well. To anybody that is still in here, the recording of this will be automatically posted to our Facebook page as soon as I close the live. So if you'd like to go back and hear the whole thing or share it with your friends and family, please do so. And again, thank you both for your time. This was really great.
Thank you.
Thank you.